All right, let's talk about polycystic ovarian syndrome. Let's say a patient comes in. What are some of the clinical manifestations that can prompt you to think about PCOS? Let's say if the patient is amenorrheic, which means it's 3 months, no menses. They're oligomenorrheic, less than 9 menses in 1 year. They're having trouble conceiving. They're complaining about hirsutism, acne, and male pattern baldness. We can use the Fairman Galway score system for hirsutism. There are 9 body parts. Um, you can score them from 1 to 4 for each body parts, and 8 plus is considered generalized hirsutism. These patients are also at risk for type 2 diabetes. Up to 80% of these patients can be obese. So, what are some of the differential diagnoses other than PCOS? Androgen secreting tumors, exogenous use of androgen, Cushing syndrome, but these patients will also have central obesity, hypertension, purple striae, non-classical congenital adrenal hyperplasia, acromegaly, primary hypothalamic amenorrhea, um, primary ovarian failure, thyroid disease, and prolactin disease. So how do you actually diagnose PCOS? We usually use the Rotterdam criteria. We need 2 out of 3. Signs and symptoms of hyperandrogenism, either clinical or laboratory. Like I said, oligomenorrhea or amenorrhea. Polycystic ovaries on ultrasound, which means you see 12 or more follicles, 2 to 9 millimeters in length, or ovarian volume greater than 10 mLs. You calculate that by using 0.5 times the length, width, and the thickness of the cyst or of the ovary. What are some of the labs that you should obtain? Either to rule out other causes or to evaluate PCOS. So we should order total testosterone. Usually the upper limit of normal is 60 nanograms per deciliter. If they're greater than 150 nanogram per deciliter, this will require evaluation for more serious causes such as ovarian, adrenal, androgen secreting tumors. We can also look at SHBG, DHEAS can be mildly elevated in PCOS, but if we see that the patient has virilization, then which will prompt us to suspect adrenocortical carcinomas, then we should get DHEAS. The value will be greater than 800 microgram per deciliter. 17-hydroxyprogesterone this is to rule out non-classical congenital adrenal hyperplasia. It has very similar presentation as PCOS. It's important to measure if the patient is Jewish descent, Hispanic, or Italian due to high prevalence rate of 1 in 30. That seems very high. 1 in 30. Less than 200 nanogram per deciliter early in the morning in follicular phase is a normal test. If they're greater than 200, then we should confirm it with ACTH stimulation test. Obviously, we should refer them to endocrine. We'll have to make sure these patients are not pregnant and they don't have prolactin or THS thyroid disease by measuring prolactin and TSH. FSH, this is for to rule out primary ovarian insufficiency. We can also get a estradiol level. We can check if their cycle is at 28 days. We can check a 21-day progesterone level to see if patient is ovulating. If these patients are on OCP already, we need to stop the OCP for 4 to 6 weeks before we can measure estrogen levels. If these patients are diagnosed with PCOS, we should also screen them for metabolic syndrome. So there are 5 criteria, and we need 3 out of 5 for them to be positive for metabolic syndrome. Waist circumference greater than 35 inches, BP 130/85, HDL less than 50 micrograms per deciliter, triglyceride greater than 150 milligrams per deciliter, and fasting glucose greater than 100 milligram per deciliter. If these patients have 3 out of these 5, they are at high risk. They are increased risk for cardiovascular disease and diabetes. So we can assess their cardiovascular risk by using one of the calculators. I forget which one. I think it's called ATP3 calculators. We can also screen them for diabetes with a 2-hour glucose test. Let's take a look. So the glucose test is so the 2-hour glucose tolerance test. If fasting is less than 110, it's normal. 110 to 120 is impaired. Greater than 126, they have diabetes. After the 7-gram oral glucose ingestion, the 2-hour should be less than 140. If they're 140 to 199, they have impaired glucose tolerance. If they're greater than 200, they're type 2 diabetes. So management, there are 5 goals for patients with PCOS. Number 1 will be amelioration of hyperandrogenism. Number 2 will be management of metabolic abnormalities and reduce risk factors. Number 3 will be prevention of endometrial hyperplasia or neoplasia. Number 4 will be contraception. Number 5 would be ovarian induction. So for number 1, if patient is complaining of hirsutism, OCP is first line. Anti-androgen added after 6 months if response is suboptimal. Usually we start with a 20 micrograms of ethinyl estradiol with norethindrome. Drospirenone has less angiogenicity but higher risk of VTE. Anti-androgenism if OCP is contraindicated or if the response is suboptimal. Spironolactone is a aldosterone antagonist. We can give 50 to 100 milligrams BID. Side effects include orthostatic hypotension, increased menstrual frequency. They need to be on some kind of birth control due to risk of feminization of male fetuses. Other anti-androgens, finasteride, dutasteride. We can start them on a topical cream, a fluoronidine cream. These patients can also have their hair removed physically. Weight loss, so part of the management of metabolic abnormalities. We encourage weight loss, diet, and exercise. 5% can receive return of ovulation and improvement in pregnancy rate. Bariatric surgery, I think greater than BMI above 35, bariatric surgery can be a potential treatment option. Endometrial protection, number 3. So OCP again is first line because it can also provide contraception and alleviation of hyperandrogenism. If OCPs are contraindicated, cyclic progestin should be used. Medroxyprogesterone acetate 5 to 10 milligrams for 10 days every 1 to 2 months. Norethindrome daily or Mirena can also be used. These not only protect endometrium, can also provide contraception. Metformin is second line to establish normal menses. 50% of the time after 6 months. Metformin. Routine dose is 500 TID daily. So if metformin, this patient needs to be on something else for the endometrial protection. Contraception for patients who have BMI of 30 and they're over 40 years old, using OCP needs to be we need to use caution when starting them on OCP. They could just be on a continuous progestin therapy, norethindrone 0.35 milligrams per day, or give them a Mirena. Ovulation induction, number 5. Again, lifestyle changes, weight loss for 5% before induction have shown to have better success rate, 10% versus 25% live birth rate. That's a big difference. Aromatase inhibitor, letrozole is associated with increased ovulation rate and pregnancy and live birth rate compared to clomiphene. 30% versus 20% live birth rate. 2.5 milligrams per day for 5 days on either day 3, 4, or 5 after menses. or a progestin-induced bleeding. If no ovulation, then we increase the dose to 5 milligrams per day for 5 days to a max of 7.5 milligrams per day. Clomiphene citrate, 50% who are going to conceive on Clomid will do so at 50 milligrams, 20 will do so at 100. Most pregnancy will occur within 6 cycles. Then last thing is metformin. Does not improve live birth rate alone or in combination with induction agents. They do, however, reduce risk of hyperstimulation during IVF cycles. So that is it for PCOS.